Ladies and gentlemen, welcome back to Chapter 7. We're almost done. Chapter 7, cystic disease, incontinence, and hypertension. That's it, folks. We're almost at the end of nephrology. Let's talk about cystic disease. Patients with cystic disease, such as polycystic kidney disease, are going to present with recurrent hematuria, stone formation, recurrent infections, and cysts throughout the body. When I say throughout the body, liver, ovaries, even the circle of Willis. They're associated with mitral valve prolapse and diverticulosis. And the most common place for cysts in polycystic kidney disease, well, it's not in the kidneys. Believe it or not, the most common place of cysts is the liver. Ooh, remember this point right here because that's going to get you a point on the exam. Now, the most common cause of death is end-stage renal disease. That's right, end-stage renal disease, folks. What's the most common cause of death in adult polycystic kidney disease? Well, renal failure, kidney disease, renal failure. That is correct. Remember, there's no specific therapy here. This is the point I'm trying to illustrate. Subarachnoid hemorrhage is not the most common cause of death in cystic disease. Remember, for some reason, we always think polycystic kidney disease, subarachnoid hemorrhage, worst headache of my life, thunderclap headache, thunderclap headache. Adult polycystic kidney disease, they're not associated with death. Yes, they do occur because they have aneurysm development in the circle of Willis, the cystic development. And so they do get subarachnoid hemorrhage, but that is not the most common cause of death in cystic disease. That's it, folks, for cystic disease. Now let's talk about incontinence. Incontinence, oh boy. Now how is incontinence going to present? There's two kinds of incontinence you must know for this exam. In urge incontinence, the presentation is going to be pain followed by an urge to have to urinate. There's no relationship in urge incontinence to coughing, laughing, or straining. It's just this pain that they need to go, and then they have to urinate. How do you test for this? Very straightforward. You do urodynamic pressure monitoring. Have I ever ordered it? No. Now, treatment, it's through behavior modification, and then if you need a medication, you can use tolterodine, trospium, darafenicin, sulfenacin, and the most common that we always see is oxybutynin. Now, stress incontinence, the way you're going to differentiate this, pain, urge incontinence. No pain, stress incontinence. Remember, it's all about pain. No pain, well, not no gain, but you're going to lose urine. So no pain is stress incontinence right over here. No pain is stress incontinence. Now, how do you test for this? Well, this is a clinical diagnosis. You're going to go to your patient, you're going to say cough. They're going to cough, they're going to pee. Diagnosis stress incontinence. That's how you test for it. Because their presentation is they're going to have leakage with you coughing, maybe even laughing. And right over here, how do you test for it? Well, you tell them to cough, and they're going to have some leakage of urine. How do you work this? Well, the way you treat this diagnosis is you're going to give them Kegel exercises. Yes, Kegel exercises, made very famous through this TV show Sex and the City. I don't watch it. And through estrogen creams. Last thing we have to talk about in this chapter, and the most important one for your CCS, is hypertension. A man comes to the office for a routine visit. Ooh, question time. He's found to have a blood pressure of 145/95. Not good. What is the next best step in therapy? Correct answer? Well, that's right. Repeat the blood pressure in 1 to 2 weeks. We have to get a couple different measurements to make sure that it's correct. So how do you diagnose it? Well, the first step when hypertension is present is repeat the blood pressure measurement in 1 to 2 weeks. You might need up to 3 to 6 different measurements to get an accurate assessment. 3 to 6? Yes, bring them back. Make sure that they truly have it. It's not just because they're nervous about being in their office. 3 to 6 measurements, then you consider starting a medication. Now, on CCS, the routine tests for hypertension cases are the following. Number one, you got to check a urinalysis, got to check an EKG, do an eye exam, make sure that they do a cardiac exam for murmur and S4 gallop. If they have hypertension, they may develop hypertrophic cardiomyopathies, and that's associated with S4, diastolic dysfunction, CHF, big problems. With this hypertension, the treatment is very straightforward. First, if they have repeatedly abnormal values, you initiate lifestyle modifications. If the blood pressure is immediately wrong, it's not right, it's high, you don't like it, send them home, repeat it. 3 to 6 times may be necessary. If they come back and you cinch the diagnosis through that, boom, right there, lifestyle modifications. Do some sodium restriction, lose some weight, change your diet, and exercise. How many of your patients have actually done this? It's not going to happen, or is it? Sometimes it does, sometimes it doesn't. But as a physician, you have a right and a duty to help your patients with this. Help them, sit down with them, explain to them what sodium restriction means. Sometimes you'll tell your patient, yes, eat less salt. How? Explain it to them. Weight loss. Explain to them, give them a target, give them a number. Dietary modification. Explain to them what foods are okay and what foods are not. My father needed to do dietary modification when he had hypertension. He was like, well, I have a slice of pizza every now and then. Well, Pop, you can't have that much pizza all the time. I know you love it, but you can't eat it. It's got too much salt. Exercise. Yes, get him to exercise. My dad was like, oh, I exercise. I walk around. I know. Well, Pop, you got to exercise this many minutes 3 times a day. When you give them a goal, 15 minutes 3 times a day, 15 minutes twice a week. Just do that, Pop. They'll do it. You got to give them goals. Just like I did with my father, you got to do with your patient. Give them goals to work towards, and they'll accompany these. Just saying these alone is not enough. Lastly, relaxation techniques. Woosah. I don't know how to do this one. How about yoga? Oh, yoga. Yes, yoga. Yoga. Relax. Yes, yoga has actually been shown to aid in relaxation and aid in blood pressure monitoring. One of my residents actually had a patient who came in with hypertensive urgency, not emergency, hypertensive urgency. She had to take her meds. Didn't have a prescription, but she was angry. She was upset because they made her wait in the ER too long. The resident said, hey, do this breathing exercise with me. That's right, do this breathing exercise with me, because at Lenox Hill, our residents are actually taught yoga to help cope with the stress of being a resident. And so what do they say? Oh, okay, sit down, do these breathing exercises. And believe it or not, she actually saw a decrease in the blood pressure. Relaxation, it does work. Now, here's the thing. If relaxation modification, if that doesn't work, or lifestyle modifications don't work over 3 to 6 months, then you have to initiate medical therapy. The first line drug is a thiazide diuretic. The most common is hydrochlorothiazide and chlorthalidone. These are the ones that we use most commonly. If they happen to have concurrent diabetes, you go for an ACE inhibitor and ARB first. Now, 70% of patients can actually be controlled with just a diuretic alone. If that's not achieving the goal blood pressure they need, you add a second agent. If the second agent is there, the drug you're going to pick is, boom, a beta blocker, metoprolol. Then you're going to consider adding an ACE inhibitor or an angiotensin inhibitor, and then you go to a calcium channel blocker. But which one goes first? Well, 90 to 95% of people achieve control with 2 meds. If 2 drugs do not work, then you add a third drug and then investigate for a cause of secondary hypertension. Remember, you have to have 3 drugs, of which one of which is a diuretic, to investigate for secondary hypertension. Now, I mentioned to you, well, which drug do you add? I just said right here, you could do ACE inhibitors, beta blockers, calcium channel blockers. Which one are you going to add? Well, boom! Check out this slide right here, ladies and gentlemen. If your patients have coronary artery disease, don't start with a diuretic, go straight to a specific medication. If they have coronary artery disease, you're going to go to beta blocker. If they have congestive heart failure, well, they're going to be on a beta blocker and an ACE inhibitor and possibly spironolactone or an ARB if they can't handle the ACE inhibitor. Why? Because they're coughing. If they have migraines, you're going to consider using beta blockers or calcium channel blockers to mediate the vasospastic effect. If they have hyperthyroidism, you're going to use a non-specific beta blocker. Treat both things at once. If they have osteoporosis, this one is really common. Osteoporosis, you give them thiazides. That diuretic is great for people with osteoporosis. Why? Why is it so important? Well, thiazides have a great little side effect profile. Hypergluc, G-L-U-C. Hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Yes, the GLU does suck, but the hypercalcemia will aid in the osteoporosis. Now, here's something you have to be careful of. Patient has depression, do not use beta blockers. Patient has asthma, do not use beta blockers. If they're pregnant and they have high blood pressure, you can use alpha-methyl-dopa, or you can use labetalol. If they have BPH, you can use alpha blockers because that's going to help them pee. And if they have diabetes, you must institute them on an ACE and an ARB. Remember, ACEs and ARBs help ameliorate the effects of the hyperglycemia on the kidneys, and so you must have them on an ACE or an ARB. Do not start with the diuretic first. Very powerful lesson right there. Now, secondary hypertension. If you see a young patient under the age of 30 or an older patient greater than 60, and you can't control them with 2 medications, and you have specific findings in your history and physical, such as a Bruy. Well, the Bruy tells you that you have closure of renal artery and possibly renal artery stenosis, or episodic hypertension and anger and just well, they could have pheochromocytoma. Or what if they have hypokalemia, hypernatremia, hypertension, boom, they have Conn syndrome. Or what if they have a buffalo hump, truncal obesity, purple striae, moon faces, well, they have Cushing syndrome. What if they come to you and their upper extremity blood pressure is greater than the lower extremity blood pressure? Well, they have coarctation of the aorta. And what if it's a female and they're coming to you with hair on the face and they're becoming hirsutized? Well, that is congenital adrenal hyperplasia. Big time problems. These are specific findings in the history and physical to aid in secondary hypertension workup. Now let's talk about renal artery stenosis. In renal artery stenosis, you're going to hear an abnormal sound, which is a bruit over the abdomen. It's auscultated in the flanks, and these patients are going to have hypokalemia. Diagnostic test of choice, well, the best initial test, renal artery ultrasound. They're going to do a Doppler along with it. They're going to see abnormal flow. And then the most accurate test could be an MR angiography, a duplex ultrasound, a nuclear renogram. Any one of those can be done next. And then the most accurate test, renal angiogram. That's right. You get in there and you take a look. Treatment, bam, renal artery angioplasty and stenting. Renal artery angioplasty and stenting. Stent open that renal artery. Ladies and gentlemen, that concludes nephrology. That concludes everything we've talked about at the kidneys. That was cystic disease, incontinence, and hypertension. I'll see you at the next section.